Dr. Younger and I are going to try and cover this topic in the next half hour. We'll try and speed it up a little bit and get you out to lunch. It's probably not as common in your practice as some of the other things that have been covered this morning. It's certainly not a bread and butter consultation that you might see every day. Having said that, patent foramen ovale in itself is a common observation that you might see almost every day or every week. The issue is whether or not they have this problem of clinically relevant patent foramen ovale that might need some form of medical therapy or intervention. And this is another area that I'm interested in. It's a fascinating topic. It's certainly not new. Surgeons have been closing patent foramen ovale probably for the last 30 or 40 years. So we've known about the clinical problem. It's probably come to the fore a little bit more in the last 15 to 20 years because of the ability to close these PFOs percutaneously. So rightly or wrongly, the threshold for closing PFOs has been lowered. The other fascinating thing is it's one of these medical technologies where we talk a lot about evidence-based medicine, but this in fact is an area where the technology and the ability to do things preceded the evidence for it. So the procedure itself became established. It made clinical sense. It's been done in the past and it continued to be performed, but the evidence wasn't there. So we spent the last 15 years in a way catching up, trying to determine whether what we've been doing for the last 30 or 40 years is clinically beneficial to the patients. And it's interesting to present it again because there's been a flurry of activity in the literature in the last couple of months. You may or may not have seen some of the reviews that have come out indicating that there is pretty strong evidence that in cryptogenic stroke that patent foramen ovale is, in terms of treatment, closure is superior to medical therapy, and I'll try and cover that in the next 15 minutes, and then Dr. Younger will go through some of the pitfalls and important aspects of imaging. So we can now say reasonably definitively, based on some recent trial data, that closure of patent foramen ovale is a good alternative or treatment option for patients at risk for recurrent cryptogenic stroke or other forms of paradoxical embolism syndromes. And this is just a timeline just to show you the arduous, long journey in patent foramen ovale to get to this point. I looked at my figures at QCG. I did my first PFO closure around about 2001. And the device I used was the Amplatzer device, which is exactly the same device that I used last Friday when I did a PFO closure. So the technology in the last 17 years and the way we do the procedure is identical. But in that 17-year period, there's been this agonizing, arduous period of debate in the cardiology and neurology community about whether what we're doing is beneficial to the patients and whether we should be doing it and who you should be targeting it. And just to give you some examples, the Closure 1 trial, and this is the other key thing actually about the trials, is that a lot of the trials that were published last month in the New England Journal of Medicine actually started enrolling patients 10 years ago. And this again demonstrates the pitfall of trying to develop randomized evidence-based trials that have low event rates and low enrollment rates because the procedure's already been done, so there's a bias towards not enrolling patients. So a lot of these trials took 10 or 15 years to complete. So the late results of the RESPECT trial, which is getting a lot of publicity, actually started enrolling patients 15 years ago. And it's only now that they're able to publish their results. There was the Closure 1 trial, again in the early 2000s, and then the other two trials that I'll cover briefly later on were the REDUCE trial and the CLOSE trial, again enrolling patients close to a decade ago. And this is where we're at now. So the procedure itself started being performed 17 years ago, and then there was this long hiatus of many thousands of these procedures being performed without a lot of randomized trial evidence to support it, but now with a lot more encouraging results in some of the trials. The other issues that I think are I've come to recognise, having treated many hundreds of these patients now, I must have done over 1,000 of these procedures now over the last 15, 20 years, it's always very emotive. I mean, paediatricians are used to this, and you're probably used to it because you deal with young patients every day. But as cardiologists, our cohort is not kids in their teens, 20s and 30s with devastating clinical presentations like a stroke. So seeing a 20-year-old with a stroke has a slightly different emotive flavour to it than a 70-year-old patient with a heart attack. So it's always emotive. They're young patients, they're otherwise healthy, and then there's this aspect that always comes up in the discussion, and I always spend a lot of time going through this in great detail with the patient. The other key thing, apart from the emotive aspect, is that trying to distinguish whether or not the PFO is a normal anatomical variant versus an abnormality. So in this room, 20 to 25% of you, or me, will have a PFO. And in the vast majority of us, it's simply a normal anatomic variant that does not require treatment. So it's very common. So 1 in 4, even on the table where you're sitting, there'll be one or two people that will have a PFO. So trying to distinguish which PFO is a normal anatomic variant versus an abnormality is the key thing. The third aspect, which I notice a lot, is that it's often missed. And Dr. Younger will cover that in more detail with his imaging, and I see this very frequently, where the patient will have some screening tests and almost invariably the PFO in a context where it is clinically relevant will often be missed because the correct imaging modality hasn't been performed. So it works both ways. It can be overdiagnosed in situations where it's a normal anatomic variant, but it can often be missed in situations where it might be clinically relevant. As I said, the trial evidence has been very slow to evolve, but now we have these 3 trials which I'll present to you shortly. And the fourth aspect is that there's no single gatekeeper for these procedures. Most of my patients that I see, probably half of them would have been referred by you, having seen them in your practice, and you have where there is a good understanding of the clinical scenario, and they come directly to me. But the other half are probably patients that have already been seen by neurologists. And neurologists, I hope I'm not speaking on their behalf, but by nature they're probably a little bit conservative, and it's often the patients at the extreme end of the spectrum that are often referred, and that may change now that we have a little bit more evidence to support that. So this is a patient that I put this up quite frequently when I do these presentations because it's striking. I still remember it. I did her PFO closure 10 years ago, but I still remember it like it was yesterday because she was only 16 years old. So it could be any one of your daughters. So this girl was in grade 11 at school. She was previously well, no health issues. She wasn't on oral contraception. And she got up in the morning to get ready for school and collapsed in the shower. And when she recovered, her parents noted that she had a dense right hemiplegia. Now, she was lucky. The ambulance was called and she was taken to the hospital where they were able to do an embolectomy from the left middle cerebral artery and made a complete recovery. She was heterozygous for factor V Leiden mutation. So there was the substrate, I guess, for thrombus formation. So there's the issue of, are you going to put a patient that's 16 years of age on warfarin for the rest of her life? And this is one other area that was missed in a lot of the analysis of the trials. You know, it's all well and good to say medical therapy is as good as closure of the PFO, but what 16-year-old is going to accept warfarin therapy for the next 70, 80 years as an alternative treatment for their patent foramen ovale? And this girl clearly didn't want that, and she ended up having a patent foramen ovale closure, and it's a decade down the track now and she hasn't had any further events. So just very briefly with regard to stroke, 2 types of stroke. Hemorrhagic strokes are probably around about 10%. The ischemic strokes are the vast majority, and within the ischemic cohort, about half of them are thrombotic or embolic events from other causes, and roughly around about 40% are these so-called cryptogenic stroke. And as you know, in medicine, a lot of things that get labelled as cryptogenic stroke, as time evolves, they're no longer cryptogenic. There are causes, specific causes identified, such as patent foramen ovale. So embolic stroke, in terms of a cardiac source for embolic stroke, there are numerous causes. Atrial fibrillation is obviously the most common, but there are many other varieties of embolic stroke, along with the concept of paradoxical embolism through the mechanism of patent foramen ovale. So as you know, and Johnny will probably explain this in a bit more detail, but as you know, patent foramen ovale in itself is not an abnormality. In fact, it's essential. You have to have a PFO in order to survive the normal development of the fetus in the womb. And the patent foramen ovale is the conduit where oxygenated blood from the maternal placenta comes back to the right ventricle as it would normally, but obviously there's no ability to oxygenate the blood in the lungs in the fetus, so it crosses over from the right atrium through the patent foramen ovale into the systemic circulation. So the patent foramen ovale, and in fact when a fetal ultrasound is done, I remember with my kids when they were having fetal ultrasounds, the technicians always check to see that the patent foramen ovale is open. So after birth, the patent foramen ovale closes in everyone. What differs is that in about 20 to 25% of patients it closes, but it doesn't fuse. And that's what's called a patent foramen ovale, which is a distinction from an atrial septal defect, which is actually a hole in the heart. So the clinical significance, as I said, most of the PFOs are asymptomatic. They're an incidental finding, and these are the incidental reports you get on an echo sometimes where a PFO is observed. And if the patient is asymptomatic, I don't even call them an abnormality. I tell the patient that it's a normal variant and there is no concern and they don't need to be closed. However, it is a potential for paradoxical embolism, and it's not really clear, I have to say. We don't really understand the mechanism all that well in terms of why it happens. We think there is a couple of possibilities. One is that the clot actually forms on the flap of the patent foramen ovale, which is why atrial septal aneurysms associated with PFO are sometimes higher risk than smaller PFOs. The other theory is that potentially we may all be forming little clots in our legs. For example, you're all sitting down for the last hour or two, there may well be little tiny microscopic clots that would normally be filtered in the lungs that we don't feel. But if they're small enough and they go through the PFO and into the cerebral circulation, they can cause symptoms like TIAs or stroke. So it becomes clinically relevant in the context of so-called cryptogenic stroke or peripheral embolism. And I've seen these embolize in just about every organ in the body out of all those several hundred patients, most commonly in the brain. We had one recently that embolized in the kidneys. I've had others in the hand, spleen, bowel, lower limbs. It doesn't matter. It just so happens that the brain obviously is clinically easier to manifest. I mean, the neurological symptoms are very easy to identify in comparison to other organs, but it really depends. Paradoxical embolism, it really depends on where the clot lands in the systemic circulation. There's the issue of decompression illness, and I call that unintended DCI episodes, where scuba divers have decompression illness despite doing all the right things with their tables, and that's the same mechanism where venous nitrogen bubbles cross over through the PFO into the systemic circulation and cause cutaneous or cerebral DCI episodes. And there's this clinical area which is also fascinating, and I won't go through that in great detail today, but there are certainly some debilitating migraine sufferers where the mechanism is actually the PFO. The more difficult area in migraine sufferers is trying to identify which ones are related to the PFO and which ones are related to other causes. I just put this up just to show you that we know that this happens. I mean, there used to be this debate about, PFOs, they're so common, it can't be clinically relevant. But in fact, we've all documented it. I'm sure Liz in her cohort has seen it. We've all had patients where, I had a patient in hospital that had a simultaneous stroke and pulmonary embolism post-orthopedic surgery, and she had an echo that looked exactly like that. You could see the clot straddling the PFO. So we know this happens, and that's where the inception of these techniques arose. Now, in terms of closing it, as I said, there's been a change in the way we approach this ever since we've been able to close these percutaneously. Rightly or wrongly, the threshold changed a little bit because of our ability to do these relatively easily. This is the device that we use most commonly now. Probably about 80% of my patients would have this device, and it's a disc or two disc, and it's the same device that's used for atrial defects or VSDs or any of those defects. There is an axle that connects two discs, and it comes compressed in a tube that allows us to deliver it from a small 1 or 2 millimeter nick in the skin in the femoral vein, usually from the groin. And you can see the PFO here with the catheter straddling through the patent foramen ovale from the right atrium into the left atrium, and deploying the device itself is actually reasonably straightforward. That's the left atrial disc, right atrial disc, held together by the axle in between the two discs. So when you see a patient that's presented with a clinically relevant syndrome, the issues that I find need a long time to discuss. First of all, young patients, like everyone else, they need to know what's caused it. Secondly, the question that they always ask me, they're terrified, they've had a stroke, they're 20 years old, and they want to know what the risk of it recurring in the future. And in fact, what we know from the initial registries that were done in the 1990s and early 2000s is that if a patient's had a stroke or a TIA from a PFO-related mechanism, their recurrence rate is actually pretty high. It's somewhere around about 10 or 15%. It varies depending on which trial you look at. But for some reason, again, like everything else in medicine, these patients select themselves out. They might not have had an event until the age of 20 or 30, but once they've had an event, somehow they've selected themselves out, and the likelihood of having another event in the future is quite high. And then they want to discuss what the treatment strategies are, which would be either medical therapy, which might be aspirin, clopidogrel, antiplatelet agents, or more formal anticoagulation with warfarin. The percutaneous approach using these devices, or surgery, which is not really commonly performed for these defects any longer. And the expectations of the patient are clearly important. So a 16-year-old is not likely to accept lifelong anticoagulation therapy with warfarin compared to perhaps an 80-year-old that may, but also that may have other mechanisms involved in their stroke. They might have a PFO, but they might also have diabetes and high cholesterol and hypertension that would be contributing to their stroke. When I see these young patients that get labelled as so-called cryptogenic stroke, and I'm sure you do as well, there's a nice simple battery of tests that you should really do even before they see a neurologist. And it's not that hard. I think they should all have a thrombophilic screen. It doesn't necessarily influence their decision. If they have a factor V laden mutation, protein C, protein S deficiency, that actually, to me, is a trigger to close the PFO, because that predisposes the patient to more clotting events in the future. But it's easy enough to order a thrombophilic screen. It's very important to try and separate the patients that are paroxysmal atrial fibrillation, and the EP doctors keep telling us from their published data that there are actually a lot of these patients actually have silent atrial fibrillation. So it's very important that they have continuous monitoring in some fashion, and there's some debate about what the best modality for that might be, but at a minimum they should have 24-hour holters to try and work out which of these patients might have paroxysmal atrial fibrillation. And then obviously the clinical syndromes that I've mentioned earlier that might predispose the patients to cardiac emboli. They should all have carotid duplex scans. They should all have MRI scans of their brain. And that should pick up dissection in the aortic arch, carotid arteries, and all the other rare stuff. I usually leave that up to the neurologists to try and differentiate. So just in the last 5 minutes, I just wanted to very briefly, I'm not going to go through these in detail, but there was this flurry of publications that you might have seen in the last month. Actually, I think it was only about a month ago that there were all these 3 manuscripts were published in the New England Journal of Medicine, and they're landmark trials that I think we'll look back on now as the change point of management of patent foramen ovale, accompanied by 2 editorials at the same time. Now, the RESPECT trial, yep, that's the RESPECT trial. We've known about the RESPECT trial about 3 or 4 years ago, but just a quirky analysis of the statistics, it didn't quite meet statistical significance in terms of its primary endpoint. It was a randomised trial comparing medical therapy against closure of PFOs in patients with cryptogenic stroke. Without boring you too much, it was an intention to treat analysis. And there was 1 or 2 patients that crossed over that got counted in the PFO closure group. So for example, there was a patient that had a PFO with a stroke that was randomised to have percutaneous closure of the PFO and subsequently had cardiac surgery and had a stroke post-operatively. And those patients, even though they cross over, they still get counted in the closure arm because it's an intention to treat analysis. So it didn't quite, there was a 70% reduction in the PFO closure group, but it didn't quite meet its primary endpoint in terms of the p-value. But at the longer term analysis in the RESPECT trial, there is a wider separation of the curves, so that you can see the closure group compared to medical therapy is clearly superior in terms of recurrent event rates. And all the lines, in fact, look identical. This is the REDUCE trial. This is probably, I think, the best of the 3 trials, because in the REDUCE trial, they didn't allow warfarin therapy. And I think that's a key thing, because if you go to compare closure of PFOs, we're not really comparing closure against warfarin. I mean, most of these patients are not going to be taking warfarin for the rest of their life. So in the REDUCE trial, they decided they're only going to allow antiplatelet therapy, aspirin, clopidogrel, in the medical therapy arm. And it was highly statistically significant in favour of closure of patent foramen ovale compared to medical therapy in terms of recurrent event rates. And then the final one was the closed trial. Again, the curves almost identical. In fact, in the percutaneous closure arm of the trial, there were no recurrent strokes at long-term follow-up, compared to the antiplatelet therapy arm, where there were a number of strokes in the same period of follow-up. Highly significant in terms of treatment approaches. The differences between the trial, they're all fairly similar. Large number of patients now. You know, in the closed trial, close to 500 patients. The RESPECT trial is probably the largest of the 3 trials. The RESPECT trial, though, did allow for anticoagulation. They didn't exclude patients on warfarin. So 30 to 40% of patients in the RESPECT trial were on warfarin therapy, which again has the problem of whether or not to use that as an alternative, particularly in the younger cohort of patients. But in other aspects, the 3 trials are fairly similar. So this is probably going to be a turning point in terms of how these patients are managed. We now have numerous registries that were published in the last decade, but now 3 good randomised trials that are demonstrating superiority of closure compared to medical therapy. Without going into it in great detail, success rates, the technical aspect of the procedure is very straightforward. The more difficult thing is the discussion that precedes the procedure. So the success rates should be close to 99, 100%. It's not that difficult in terms of other things that we do. The procedural complication rate is low, and in fact it's no different to the medical therapy arm in terms of atrial fibrillation, bleeding risk, and DVTs. And finally, just some very simple things about management post-PFO closure. If you happen to see a patient that's had a PFO closure, I follow them up reasonably closely for the first year or 2. They should stay on dual antiplatelet agents somewhere between 3 and 6 months. We're not as rigid as we are with stents in PFO closure, but they're still on aspirin and clopidogrel for about 6 months. They have antibiotic prophylaxis. Minimum is a year. I tend to continue it for between 1 and 2 years for contaminated procedures. They have a imaging surveillance on day one, which is in hospital, and then they have another one at 6 weeks, 6 months, and then a year later, then perhaps second yearly after that. The device is held together by its spring mechanism in the first few weeks. So I tell the patients to avoid extreme strenuous activity and to avoid Valsalva manoeuvres. Not that the device is going to be dislodged, but to try and avoid those sort of activities that might have an impact on that. I've had patients actually have pregnancies. You know, some younger patients that I've told to try and avoid pregnancy in the first 6 months. We've had lots of patients now that have had unintended pregnancies and there haven't really been any issues with that. The patients to consider post-embolic events or paradoxical embolism in the systemic circulation, scuba divers that have had an episode of decompression illness. This is the recreation scuba divers. Technical scuba divers get mandated to be screened for PFO, but not recreate. If any of you have a scuba license, that you don't get screened for a PFO. It's only when there is an unintended decompression illness episode that they become screened for PFO. And then there's this debatable area about refractory migraines despite medical therapy. So some of the take-home messages: PFO is common, most are not significant and nothing needs to be done for them. It can be closed percutaneously in clinically significant scenarios. Johnny will talk to you about the best imaging modalities to screen for these PFOs, but remember that a plain transthoracic echo with colour Doppler will miss probably 60 to 70% of PFO, so it needs to be a targeted imaging modality. It's different to an atrial septal defect. Atrial septal defects need to be closed because of volume loading, whereas PFOs, they don't have a hemodynamic consequence. So I'll leave it at that, and not sure if you...